Can we start the lecture, please? Last year I was in Kolar in Karnataka, where the first talk after lunch was by Dr. Mahesh Vakamudi of Ramchandra Medical College in Chennai. And he said that if a speaker is given the first talk after lunch, it is either because the organizers don't like the speaker at all, or they have sufficient confidence that the speaker can keep the audience awake in the first lecture after lunch. So let us see which way it goes. I've been asked to speak on how to read adult spine with ultrasound anatomy. Is it indeed possible? As with anything else, to begin with, it is difficult, but if you practice and persevere, it is indeed possible. Neuraxial blocks is something we all grow up right from our first few days in the anesthesia program, and we are very, very comfortable doing. And we are quite happy to do a spinal or an epidural or put in an epidural catheter. So we practice neuraxial blocks very often. The end point with a neuraxial block is well defined. If you want to do an epidural, you have to stop short of puncturing the dura. And if you want to do a spinal, you have to puncture the dura and then elicit some flow of CSF before you put in your injection. And there is a lesser anatomic variability also with regard to neuraxial blocks when you compare it to peripheral nerve blocks, where there is a huge anatomical variability that you can encounter. And the reliability of a motor block or a sensory block, say with a spinal, is definitely almost 100% when you compare it to the variability you can have with a peripheral nerve block. On the left here, you have the dream spine. You can see the lumbar spaces and the spinous processes staring out at you and asking you to actually put in a needle. And on the right is actually the nightmare spine. What happens in such a spine is that A tries to do an epidural, tries a couple of times, then B takes over, and then finally C takes over and somehow manages to site the epidural and put the catheter in place, provided the patient has not swooned in the meantime because of a vasovagal. When you come back to these dark lines here, you will agree with me that these are Trophier's lines, and they are supposed to correspond with the L4, L5 intersection. Can any of you just tell me, when you palpate a spine and say this is L4, L5 interspace, how often we are right? Take a guess. 90%? Absolutely, absolutely. Someone said 30%. That's absolutely correct. You're correct only 29% of the time. 51% of the time you're one space higher, and the range is from 4 spaces higher to 1 space lower. The other thing you should know is that most of us practice epidurals by using the laws of resistance either to air or saline. This was taught to us by Dogliotti way back in the 1930s. Some of us practice the hanging drop method, and Dr. Silliman was just telling us that when you do a cervical epidural, he prefers a hanging drop. This was taught to us again by Gutierrez. This was also in the 1930s. So for the last 80 years, we've been practicing what has been taught to us in the 1930s. So it probably is time we apply some technology to our practice of neuraxial blocks. Why do you need ultrasound guidance? One is you can accurately determine the spinal level and the interspace. You can accurately localize the posterior midline. You can determine the distance from the skin to the ligamentum flavum. You can determine the angle that the needle has to take. And if there are any anatomic abnormalities, for example, a kyphosis or a scoliosis, or a lot of scar tissue following a laminectomy, you will be able to pick it up with an ultrasound. So are there problems with ultrasound guidance for spine? Yes, there are. Because before we go to those steps, I'll just recount for the sake of juniors in this audience. You have the skin, subcut tissue, supraspinous ligament. Then you have the spinous processes. In between is the interspinous ligament. Then you have the ligamentum flavum and the dura, the thecal sac. What is more important and what you see with ultrasound is you see the posterior dura there. Then you also have the anterior dura, the posterior longitudinal ligament, and the margin of the vertebral body. That forms what you call an anterior complex when you see an ultrasound. So the problem with ultrasound guidance for neuraxial blocks is that the structures are enclosed in a bony cage, and you know that bone does not transmit ultrasound waves. So it is quite difficult trying to pick up structures in between the windows that you have between these spinous processes. So the angle for which you can view these structures is quite limited. And these structures are present at a greater depth, which means you need to use a low-frequency transducer, which by definition does not give you a very clear image. And that is the problem when you use a low-frequency transducer. Ultrasound-guided technique can either be done offline as a pre-procedural scan. That is, you just put in the ultrasound probe, you identify the space, you identify the depth to the ligamentum flavum, and then you put the probe aside and go ahead the normal conventional way. And the other way of doing it is real-time guidance, which requires two operators. And in adults, we've not reached a stage where we can do it with real-time guidance. So I'll be talking basically about the offline pre-procedural scan. And when you scan the spine, there are two views for the spine. One is the longitudinal view, and the other is the short axis view or the transverse view. So this is the spine over there, the sacrum, L5, L4. These are the intervertebral discs. And this is the curved low-frequency transducer that is applied in the midline over the sacrum and the L5 spinous process. So as you see here, the continuous line of bone, which is this, is the sacrum. Then there is a dip there, which is the S1, L5 interspace. Then there is a small hump which is formed by the spinous process, another dip, which is the L5, L4 interspace, and then another small hump, which is